Good evening, everyone. It is my pleasure to introduce Dr. Marinella Galea. Dr. Galea is the Chief of Spinal Cord Injury and Disorder Department and the Director of the ALS Clinic at the James J. Peters VA Medical Center in the Bronx. She is an assistant professor of physical medicine and rehabilitation in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai. Since 2017, Dr. Galea has been a member of the Veterans Health Administration ALS Executive Committee, which provides clinical, educational, and research guidance in support of strategic planning, national initiatives, and professional practice for veterans with ALS. Dr. Galea is a graduate of the University of Milan Medical School in Italy. She completed her internal medicine residency and spinal cord fellowship at the Icahn School of Medicine at Mount Sinai. Just a quick note before we begin. Please enter your questions into the chat and we will get to them at the end of the segment. Also, if you would like to send your questions anonymously, we ask that you click on the Send Anonymous button. Welcome, Dr. Galea, and I will turn the mic over to you now.
Thank you, Tracy. Thank you for the kind introduction. It's an honor and a privilege to be here and talk with you. And thank you for the Greater New York chapter for inviting me. Let me share my screen so I prepare a little bit of a introduction so that hopefully it's going to work out. Yes. All right. And let me just get rid of the image so you can see. So I prepared a little bit of visual because I like visuals. I think they are helpful if we need to understand what's happening. And hopefully
Pardon my interruption real quick. We see your presenter view and not the full screen presentation. Okay. If you just go over to the top of the screen where it says display settings in the upper left-hand corner.
Okay, display settings, yes.
Yes, click that. And then click that one right below it says swap presenter view and slideshow.
Yep.
There you go. Thank you.
Good. Thank you. As you can see, I'm technically challenged, so thank you for the support. Okay. So as I was saying, visual are usually helpful, and hopefully they're gonna help to keep everybody awake. Just the disclosure. I want to make sure that, first of all, to let you know, you all know that I'm a proud VA employee. I'm proud to work for the VA. I've been working here specifically at the Bronx for a very long time, 20 years. And the disclosure is that I work for the Veteran Health Administration. Some of you may know that the VA in general is comprised of three different sections. One is the Veteran Health Administration, here I come, and one is the Veteran Benefit Administration. Anything has to do with the stipend, with the pension, falls under their umbrella. And the National Cemetery Administration. I'm sure I don't have to tell you what that is about. So again, just making sure you understand that this is where I live. I have partners that help me to understand the rest of the VA, and I will share those partners with you. But for the sake of this presentation, that's what I represent. So some of you may know, some don't, that there is a reason why we're talking about veterans and ALS. Historically, there are 4 studies, 4 epidemiological studies, so studies that look at the prevalence and incidence of a condition in a specific population, right? There are specifically 4 of them that found some linkage between ALS and having served in the US military. 3 of the studies evaluated specifically veterans from the 1991 Persian Gulf War, while one looked at veterans that served prior to that, from all the way from 1910 to 1982. So those studies shows that there was a higher prevalence of ALS in veterans, people who served in the U.S. military. Based on those studies, the Secretary of Veteran Affairs at that time, in 2001, Anthony Principi, made a policy decision. So basically a unilateral decision that says, we want to provide disability compensation for veterans who served in the Gulf War. So that was a very, I'd say, narrow choice at that point, because up to that point, that's what we had. We didn't have anything else that could help us to better understand the significance of military service and ALS. As you can see from the slide, hopefully you can, these refer to a period of service between August 1990 and July 1991. So moving forward, and based on that information, the Department of Veteran Affairs basically tasked or asked the national academies, which is the entity that is most suited for, to conduct an independent assessment, looking at the possible relationship between the military service and the development at the later date of ALS. And this is basically what came up. Is a whole book, so it's not like an easy read for sure, but it's something that is considered a little bit of a Bible for us, because in a very systematic way, the scientists looked at the evidence, the medical and scientific evidence that is out there that links ALS with veterans. Now, the Institute of Medicine concluded that based on the evaluation of the literature, there was limited and suggestive evidence of an association between the military service and the later development of ALS. What does this really mean? So it's limited. It's limited not because we have done large studies, we look at a lot of people, just because, in these few studies that were out there and were well conducted, there was evidence of that suggested a correlation, meaning that it was not, absolutely obvious that there was a cause and an effect. Let's imagine, for example, some other condition. Some of you know that, again, I'm the chief of spinal cord here at the Bronx, and we do care for veterans with spinal cord injury. So a veteran who was driving a military vehicle during their active duty, suffer a rollover and develop spinal cord injury, clearly they have a cause and effect, right? So the injury, the problem was caused during service. Again, in ALS, that is not so clear. There is suggestive evidence. Nevertheless, ALS was deemed to be a presumptive disease. Presumptive is a very important word for VA, because it means that it is assumed that a veteran acquired the disease as a result of the military service, which means that there is no need to prove a connection. Another example that I can make that is going to explain better why this wording is so important is because also at our center we care for a veteran with multiple sclerosis, which is a condition that can appear as a disturbance of the eyesight or a little weakness, and then nothing for years, and then years after you have a full-blown problem or you're diagnosed. Well, in that case, for multiple sclerosis, a connection must be established. And sometimes it's not easy, right? How many veterans we see that served 20, 30 years before, and how difficult it is to go back and find a single incident that caused the problem. So this is not necessary for ALS. Now, the thing that is important and is necessary is that someone has to be on active duty or have at least served 90 days of active duties. We do receive quite a few consult and requests every year regarding veterans who were in the National Guard, but never quite had any active duty besides the active training for 30 days. So that is not considered enough. And I do understand people sometimes think it may be unfair, but again, based on the fact that there must be scientific evidence of the correlation, the study done so far, look at veterans with more than 90 days of active duty. Now, the Institute of Medicine not only came to that conclusion, but also made some recommendations. So they asked that moving forward, there are studies who explore what are the existing group of study designed to look further into this issue, and also identify any risk factor that is believed to be the cause of the problem, and to conduct even more studies to corroborate, to establish a connection or a culprit. So in 2008, as I mentioned, ALS became a presumptively compensable illness for all veterans with 90 days or more of continuous active service in the military. So far, here we are. Now, I wanted to point out, this is 2008, right? So good. So at least we have established something that is important and is a milestone to move forward from. It took a few years until 2014 for the VA to come up with a directive. For those who don't know, we use a lot of directives. And basically, these are guidelines that the VA put up to enable the team or the people who take care of this kind of condition to have the necessary tools, the necessary resources to provide the care that people need. Specifically, Dr. Graf was the chief of neurology at that time. He was a infatigable supporter of ALS, and is thanks to all his work that this handbook was created. Again, it was the first one, so it was the beginning, it was not perfect, but it kind of said that, the VA wants to make sure that persons with ALS and veterans with ALS receive the care that they need, and that they all have access to that care. And then also they requested that whoever was in charge created the structure necessary to provide that care. So that was a fantastic first step. Some of you may ask, okay, but how many veterans are we talking? How big is the problem, right? Some data, again, is not perfect because the VA is a big data-driven system. You might have heard me saying that in the past. But as far as we know, we serve about 4,000 veterans within the VHA, the Veteran Administration. And of those 4,000, about half of them, 1,900, receive care at an SCI center or a spoke. For those who don't know, again, I'm proud to be, heading one of those here in the Bronx. And there are 25 of us scattered throughout the United States. And we have spokes. So we have centers that we are responsible for that allow us to reach out to the periphery of our region. For example, here in the Bronx, we have 3 spokes. So one is Northport, Long Island, the other Hudson Valley, and the other one is Manhattan. So we work closely with the team in that area so that we can provide the right care. Now, so that it's clear, I want to make sure that I don't mislead you, misguide you. We are here in the Northeast, but there are centers also in other areas. Some centers have the ability, the tools, and the structure to provide care for conditions besides spinal cord, such as ours, Orange, Syracuse, Richmond. Other centers cannot. For example, Seattle, as you can see, is serving a huge area here in the United States, and has a lot of spinal cord injury, veterans that cares for. So cannot take under the umbrella of the Spinal Cord Injury and Disorder Centers the care of veterans with ALS. However, Dr. Liliana Howard, who's a fantastic rehab physician, has created an amazing ALS clinic in that area and runs the clinic through her service. So, and it's about the same here and everywhere for us. in VA. Just for those who don't know, our system of care, the spinal cord injury and disorder specifically provide lifelong care. So if you're followed by us, you have access to rehab, medical surgical care, primary and preventive care. I'm personally an internal medicine doctor by trade. But again, also access to medication, supplies, prosthetic, orthotics. You all can read, so I don't want to, read it for you. Some of our centers provide also long-term care, not specifically here at the Bronx, but we have areas in the VA where we provide long-term care. So, sorry for that. Again, when you talk about ALS, you want to talk about interdisciplinary team. That was one of the first things I did when way back in 2016, I started 14 or 16, started the ALS clinic here, and modeled on the larger or more equipped and more experienced clinics, private clinics here in the New York State area. We have all those people, and I realized after that I missed the nutritionist. My apologies. But we do have a neurologist. Some of you know that here at the Bronx I've been extremely fortunate because I had the luxury of working with Dr. Jinsey Andrews, who is actually going to give a fantastic presentation if she hasn't already done so on research in ALS. She's here part-time with us. She's an amazing physician and neurologist. And I would be remiss if I didn't mention also Dr. Matthew Harms, who has worked with us in the past and now is returned to Columbia. And again, also Dr. Noah Harrell, who is our neurologist, who's going to give a presentation later on this week. We do a lot of rehabilitation. We have physical therapists, occupational therapists, and respiratory therapists, psychologists. We have access to prosthetics. One of the thing that is really made a difference is also have on board with us Dr. Lindenberger, who's a palliative care physician who joined the team since the very beginning. Not every team in VA has one embedded in their team, but they are available if needed, and they work closely with the team. And again, speech, social work, pharmacy, you name it. Moving forward, some of the initiatives that we have at the Bronx, but we have in many other centers, Tampa, Cleveland, again, Seattle. We will lead support groups. So usually they occur on a monthly basis. We provide caregiver education. I don't know if any of you had the opportunity to participate to our caregiver boot camp 2 years ago, which we are looking to repeat this year, hopefully when COVID disappears or improves. Just to support the brave and indefatigable caregiver that care for our veterans with ALS. We also provide clinician education, which I thought I think is a key to just make sure that we reach everyone. As I mentioned, we work as a hub and spoke. So I need to make sure that whoever, if any of my veterans live in Manhattan, all the way in Long Island, there is a team of people there that know what is ALS. We are there to support them, but they need to know because they may be my eyes or hands on the field, right? So we with them quarterly. We have frequent interaction. We coordinate care all the time and provide as much education as we can. We also provide advocacy, and I'll speak a little bit about that as I move on, and research. You probably, as I mentioned, Dr. Andrews worked with us. She has a lot of research studies going on. And Dr. Harrell also works directly here at the VA, has another very interesting study on magnetic stimulation. So more to come. For areas where there is no spinal cord injury centers or a specific ALS clinic, just so you know, the VA works in pack teams. So this is a way for us to make sure that we provide the care as a group, as a team. Also, if we are not actually a full team, but at bare minimum, we have a physician, an RN, and the technician who work together to ensure that there is continuity, that people don't get lost through the cracks, and we partner with the veterans to provide the right care. Also, again, when it's not in an SCI center. A lot of you have used telemedicine, I'm sure, in the past year during COVID. Again, the VA, I'm proud to say, is at the forefront of telemedicine. We can provide the technology, can provide iPads to the patient with 4G, if not FG, connectivity so that they can communicate with us. They don't necessarily need to come. I totally sympathize with people saying this is a tough time, Not only I don't want to take the trip, but I want to make sure that I speak with my doctor, I see my doctor, they see me. We check on the caregiver and we can do a video. So we can definitely do that. But we also have tools like My Healthy Vet, where any of our veterans, like a lot of hospital nowadays, have your electronic chart, and you can go in and read what was done, and look at your labs, and so forth. And then secure messaging. Not sure if any of you is followed here, if you had the opportunity, but I start my days usually with a few secure messaging and that I can answer quickly, and I finish my day with few secure messages. One of the things that I find really helpful, especially with the ALS, is that as speech become a little more impaired and communication is a little more difficult, the ability to type a question or to just state something firmly is important. And having it in black and white, and me being able to provide a black and white answer as best as I can, and an answer that is then recorded in the medical chart is really important because number one, I'm getting older and I forget. So it's going to help me to remember what we talked. And then it's going to force me to just give first, not only myself, but as clinician, answer in a timely manner, in a concise and clear manner. And just a word about REC-ICC. So in the last year or so, maybe a couple of years, VA has moved to try to consolidate and the care in tracks. Imagine, that there are several ways to get to a place, and whoever is driving similar vehicle is asked to go in a certain way. Kind of an odd similarity thinking about it, but in any case, we has been in the rehab field are lumped together with and work with, coordinate with programs such as the home-based primary care one, which some of you may be on or not. Basically, they are our hands in the field. Remember the mention I did before of these groups of people, which can be a nurse, a doctor, a psychologist, a therapist. They go to the patient home and provide direct care to the one who are homebound or have difficulties traveling, right? Problems traveling. So we are, we connect with them at least once a month. We have a common meeting, and this is inclusive of all our region, which is called Bison. So we become friends, we know each other, and when you know someone, it's so much easier to work with them, right? To collaborate. We also work closely with the GEC program, which lumps basically the home health attendant program, skilled home care. I know home health attendant is always a difficult subject to deal with because it entails for us, physician, to specifically for nurse to request that the VA provides some purchase care through local agencies, and there is always a limit in the number of hours we can provide. But through this partnership with the GEC program, we have consolidated certain pathways so that we know exactly what to do. We know which route to go, and what we can what we can tell the veterans to expect. Clearly, all these has become a little more complicated in the last year because, as you know, as we have taken a hit with COVID, a lot of the agency out there have. So there have been less home health attendant available through the specific agencies. And then when they were available, then became positive. So the patient has a problem. So again, hopefully moving forward, this process is going to be less complicated. And please, let's all get vaccinated. I just have these two words. So again, also in the same track, we also have hospice programs within VN, and we provide respite care. I think is again, please take this presentation with a word of caution. Again, at this point, I cannot physically offer respite care unless there is a true emergencies. And one of the reasons is because our wards are still kept, I would say isolated, but I would rather use the word safe by only allowing admission who are urgent or emergent, which does not quite include the respite care at this point. And as we get more vaccination out there and the prevalence decrease in the community, I'm really hopeful that I can open our door to more assistance in that case. There are inpatient but also outpatient respite care programs available. Now, one of the things that honored and proud to be involved with is the VA ALS Executive Group. So this is an initiative that came about when the directives I mentioned before were due for a redo. Every so often, we need to look at the directives and make sure they're up to date, right? So just about that time, Dr. Higgins, who was the chief of the neurology service for all VA, approached a group of us, which at the time was 6 people. I'm trying to count as I'm speaking. One of those was Francis McKellan, who I don't know how many of you know, was a fantastic advocate for ALS, based in Cleveland, now unfortunately retiring. But she and Don really were so proactive and committed to create a group of cool experts. But again, please, I'm fortunate enough to be part of them, but certainly not such an expert as some of my co-friends, co-committee people. I don't know how to say that. As you could see, Richard Bedluck worked with us. For those who know, he is the creator and the mastermind behind the ALS Untitled. I'm lucky to speak with him quite often through this committee. He's an amazing physician. As I mentioned, Eliana Howard, she's also working out of Seattle, fantastic person, very much involved with the new generation of the electronic medical chart that is coming to VA, which is supposed to help us to work better and more streamlined. And Dr. Yunus Patwa, he's from Yale and the chief of neurology at Connecticut. Christina Fournier, also an amazing physician and the neuromuscular specialist. Moving forward, in 2020, recently, Dr. Higgins moved on to another position, and now Dr. Martini and Graham are the new neurology and deputy neurology chiefs. They're also extremely involved with ALS and determined to make a difference. Dr. Kaur also joined our group. She's also a neuromuscular specialist and in information technology specialist. So a lot of good people working together and trying to do good. Let me tell you some of the things that are in the pipe is, for example, two things. The first one is the new directives, which we're working on, and hopefully is going to be strong, updated, and ensure that the care for ALS veterans is equal and available everywhere. Streamline the process of requesting purchase care outside VA, which is comprehensive when it's not available, and also the creation of a new internal ALS website that is going to be used by any physician in VA and any clinician in VA who has a question, a concern about ALS. They can go there, it can be their sources. So if you live in Timbuktu rather than, I'm sorry, Timbuktu is not in America. If you live in a remote area in the mountain, I don't know where, or if you live in New York, you can still go there and get the same information. So that's really going to be helpful. Now, coming to benefits, right? As I said, I'm no expert, so I've learned by living with people who needed these things, and I learned as much as I could. But I'm going to then refer you to some of our partners who are much more expert than I am. So just a brief overview, as some of you may know, Service Connection entitled ALS Veterans to a Special Monthly Compensation. Now, there is much to say about it. I know that most are aware that there is being service connected means that you receive some compensation. However, there are several degrees of disability that are entitled to different amount of compensation. Now, I always tell my patient, you really don't want to get a lot of money at the end, because the more money you get, the more disabled you are. So yes, you're entitled to it, but let's this is the whole idea. So let's go step by step and try to make sure that as a physician, when I fill the forms that I have to, I highlight what is wrong with you, what is not working. Maybe that you're weak in your legs, in your arms, or you have difficulty breathing, or you have a PEG tube, or you're using a machine. So I make sure I specifically describe the problem, right? Because that's my job as a physician. I have to tell them, I have to write in a form, which is black and white, what I think. And a lot of time, I'm not allowed to a lot of sentences. I cannot romance it out. I have to say what it is. Once I fill that form, the form goes to the Veteran Benefit Administration that I mentioned at the beginning of the presentation. And then there are raters. Raters are non-clinicians, so people who have received training to rate the veterans according to the level of disability, which they calculate based on my determination, my description. Excuse me. So this is in black and white what I do. We try to, as physician, we understand that what is good today may not be the same 3 months from now. So we try to update those forms as frequently as possible. But with that in mind, we also know that there are specific changes that warrant a change in the compensation, which we're not particularly privy to. But again, small changes are probably not significant. So that's why we always ask you guys, to see each other every 3 months, or, if the disease, I'm knocking on wood, is stable, every 6 months. And at that time, we will compare what we have observed to the previous form and see if there is any change that needs to be done and update it accordingly. And then, send it to the VBA. Aided attendance, interesting concept. So aided attendance is Something that the VA came up as a token of appreciation for the person providing the care. So please don't see that as a stipend, because clearly that's not a stipend, it's a small amount. I don't even know how much, but I'm thinking is really small. Can be given to a family member or a close friend, not to somebody who's hired, and helps to, again, to the VA saying thank you for going the extra mile and do what you're doing. It needs to be person specific, so we have to have a name of the person, and it goes with the DBQ, the disability form. So it's not something done outside that. So you have to have one to have the other. Caregiving program, that's an exciting program that the VA had established way back to 9/11 for 9/11 veterans. That program provided support in the form of a stipend this time to a caregiver of a veteran who suffered severe problems during their service in that area, in that time frame. The program was very limited, and clearly the VA started it for a reason, which was directly connected with the 9/11 episode. As of the beginning of this year, end of last year, this program has been extended to more years of service. Is a little complicated, and they have a whole service that does only that. So for whoever is interested, again, I'm glad to share or to point you to the person here that I know at the Bronx who actually is an expert, because there are a lot of forms to be filled. The person who's actually going to be appointed as a caregiver is going to require to have a NPI number, so a national provider number, and is going to be paid by VA to provide the care. We were told that in some cases, if not all or most of them, whoever receive this type of compensation will not be able to receive also the home health attendant through the purchase care on the outside. Apparently is case by case, so I don't want to put a blanket on it, but again, this is why we have experts, this is why people went to training to learn how to apply these rules. We have the VA's life insurance programs, adaptive housing grant. I know a lot of people use them. Again, that said, is the process. So you have to have a home evaluation, then you have to have the evaluator come to your home and give you some ideas. Then we need to have bids from contractor for the modification to be done. So it's not something that happens 1, 2, 3, but I do have quite a few veterans who took advantage of that and were able to have their modification paid for. There is a veteran mortgage life insurance, which is apparently very convenient. We have automobile allowance and adaptive equipment. Most of you know by now, I hope you do, that the VA will pay for ramps, lifts, ceiling lifts, hospital beds, anything that's adaptive, ECU, so environmental control unit, the Alexa, basically, that we pay for all these things. So automobile is important because we want to have an accessible vehicle where our ALS veteran with ALS can go around with. If they cannot drive, their caregiver can drive. And this again something that is absolutely, it's actually I think not as difficult to obtain from what I'm told and from my patient experience. There is also clothing allowance, which I think I only look at one time. Only one of my patients was interested. And then there are benefits for dependent, such as dependent education assistance, somebody with young children, the VA will have to pay for college, I believe, and some survival benefits. Again, very quick overview. I would recommend, if you have serious question about that or in-depth question, there are several people who can give you information. My experience is that, my long-time experience is that the Paralyzed Veteran of America is really an organization that is dedicated to provide the right information. Not only that, but I've seen that when we ask their help to process a claim, to make things happen, they go the extra mile. And again, I don't want to only advertise them, but I can speak from what I know, and I feel confident that this organization will deliver. I also have to say that I'm lucky to work with Amaris Polanco. He's our service officer here. Is here in virtually these days. I spoke with him before this presentation, and I mentioned to him that I really wanted to share his information, and he has agreed to. So that's why I put specifically his email there. Again, one of the advantages is that it's not only knowledgeable, but their office is actually next door to the Veteran Benefit Administration, which is really helpful. Maybe not during COVID, let's face it, but rather than shuffle a form to the mail, to hand deliver it next door is important. Word of wisdom, clearly you have to, whoever works with them have to give them healthcare proxy for that specific limited assistance they provide. So that we know. Moving forward, actually I already touched on that, some of that. Again, I spoke about the new ALS directives, which promise to be a good, how can we say, script for to provide ALS care equitable and access to the care everywhere in the United States, no matter which VA you're using and which spinal cord injury you're using, center you're using. The Safe Life Act, first and foremost, just make sure that you know that the VA provide vaccination, COVID vaccination to every veteran with ALS, no matter of the age. We prefer if the veteran goes to their VA of the home VA. For example, in my area, if somebody's home VA is Harbor, I would recommend they go there just because we are allocating a certain number of vaccine depending on the number of veterans enrolled. So, somebody from Harbor comes here, we may find ourselves with less vaccine than Harbor and vice versa. As of last week, this new act, which was really widely publicized, so I hope you already heard about it, if not from us, but from the news, basically state that COVID-19 vaccination for caregivers is available. And the caregiver does not need to be the wife or it can be anybody that provides the care. So at this point, we have asked for all our ALS veterans, and if you have heard yet, I'm asking now that you go on the website, and I can share the link after. I apologize for not embedding here, where you can sign up, and based on your VA of origin, they will then allocate a certain number of vaccine, and they will have to have proof of connection, right, between the veteran and the caregiver. Therapeutics. So if you follow the news, there are a few therapeutics, a few things that seem to help with ALS. We specifically have a neurology pharmacist nationally that work with our group, not on a regular basis, but a consultant. And they look at all these, the new medication, the new intervention, and then they work with the company to provide the medication for our veterans with ALS. That has been the case with Riluzole, with the Daravon, and I'm sure we continue to provide it. Yes, I know the VA tends to be not as quick maybe in providing medication, but please know that we want to provide safe care, we want to provide safe therapeutics, and we want to make sure that whatever we give you, again, at no cost, that is convenient, that is easy to administer. Some of you may know our pharmacy, Jesse Robertson. He's an amazing, absolutely amazing person, and has worked so hard to really establish system that make it super easy for patients to receive everything that they need in terms of medication. Research, as I mentioned before, I'm lucky enough to work with fantastic researcher and neuromuscular specialists. Also, before I finish, I really have to mention Ernest. I'm not sure how many of you know Ernest. Ernest Champon is our RN coordinator. He's an invaluable help and joined our team a few years ago, but his drive and attention and dedication to our veterans is infinite. He has so much more patience than I have. So if you don't know him, just for the sake of it, you should stop by and get to know him. I spoke a very long time. I hope you're still awake. And I hope the visual helped. I wanted to close if there are any questions, but for sure I would like to hear from your side, which is your experience as a veteran with ALS. And I really would like to know how we can better assist you and your loved ones. So with this, I really thank you for your attention, and thank you. It was really a pleasure.
Dr. Galea, thank you so much. I'm just going to jump in and flag the 15-minute warning. So we have enough time to take questions if there are any. Vivian will give those to you, and then we will certainly get to your questions. I also want to give a shout out to Ernest. He is great. Everyone at the chapter really appreciates his dedication and hard work with everyone else on the team, from April to Carmen to everyone else. Thank you so much.
Wonderful. Thank you, Tracy, and thank you, Dr. Galea. That was incredibly informative. One question that we have is around research. If there are any particular research trials or opportunities available to veteran PALs through the VA.
That's a good question. So for sure, Dr. Harrell is conducting a research with the magnetic stimulation to see if there is an improvement in balance and strength. I would really recommend to speak with him. Also, we partner with again outside neuromuscular specialists. I would encourage you to listen to Dr. Andrews' talk, because through her we collaborate continuously, and then she has compiled a list of research ongoing, not specifically only at the VA, but we are really supportive of whatever effort are done outside.
Wonderful. Thank you. Can you also talk a little bit about the telehealth delivery model, maybe even as it relates to anything that's changed since the pandemic?
Yes, absolutely. That's telemedicine is my first love. I think we were early adopter. When I started here, they asked us years ago if we wanted to pilot a program, and we grabbed the opportunity, started with video phones, which were really patchy, and moved all the way to being able to conduct video visits through, again, iPads mostly. The technology has advanced so much that now we also can distribute extensions so that we can listen to the heartbeat or the breathing, but planning also, and again, this is more than a national project, to acquire home-based spirometers, because as you know, one of the limitations of this pandemic was the inability to bring the patient in to complete breathing tests, pulmonary function tests. And again, going back to disability, the decrease of the functional vital capacity measured through those instruments is important, to increase or decrease the level of disability, right? So we were not able to do it. We haven't been able to do it for a very long time. So we found this company at national level who we were going to work with to provide spirometer in the home and monitor the patient and the level of function. Another things that we do and we commonly prescribe to our patient is called the Any app. Is a application as it is that goes on your phone, and you can log in anything from blood pressure to diabetes to finger sticks, and I see them automatically as I come in the morning and can give advice on how to proceed. So really, it's not only the ability to see each other, but the ability to acquire information via the technology that can help us to put everything together and give the best advice to our patients. We have done transfer training, looking at, our veterans, how to move from point A to point B when we couldn't be there with them, assisting the caregivers. We've done home evaluation this way because, the veteran needed a ramp, needed to have a specific lift, and we needed to know the measurements. So having the caregiver there with the measuring tape and us with the video has really helped to overcome obstacles.
Wow, that's really amazing. What has been possible. Are there any other, developments since the pandemic that you feel like have made more headway since just in working with patients through the telehealth?
There are a series of things that are in the pipes. One of them is I can show you the tablet, but it's a simple tablet. We're partnering with a company based in California that is producing avatars. They've been using them to so far to treat loneliness and increase compliance. Basically, is a super cute character that comes up in the tablets in the morning and get to learn the habits of the person and remind them of to take the medication or to change their position or talk with them. We've done a series of surveys during the pandemic, towards the end of the pandemic. One of the things that really came out is the fact that not only the disease was devastating, but the loneliness and the isolation that was suffered was incredible. A lot of my veterans actually end up not letting home health attendant in the home because they were afraid they would bring them COVID, and they were afraid that they would catch the disease and be seriously ill from that. So the ability to have someone to relate with and to talk to, listen music with, or read a book with them is really innovative. It's done tremendous. It provided tremendous improvement in general in the population. So it's something we are working on.
That's really amazing. Thank you so much for sharing that. Are there any other questions anyone would like to send in? We have a few more minutes. In the meantime, I'll just ask Tracy, do you have any additional remarks that you'd like to add, Dr. Galea?
Thank you. No, just thank you again. Thank you for this wonderful presentation. Thank you for everything that you do for our veterans and our pals and being so available to us. So we appreciate you, Dr. Galea.
My pleasure. Thank you for the support. It's a partnership, right?
Absolutely.
So hopefully, if anybody has additional question, hopefully my email is going to be available. I'm obsessive compulsive. I read my email, so please feel free to email me.
Wonderful. Yes, please, if anyone thinks of other questions you'd like to ask Dr. Galea after, we're welcome to facilitate those to her.